Dear colleagues, we want to present our new device which me and my colleague Dr. Mishev&Marashi had developed. It's called Suprachoroidal space needle. We call it Mishev&Marashi needle, and we want to show our technique and early results after our preliminary cases. This is our team, me, Dr. Marashi, Farhat Abrar, Arush Kuraha, Dr. Mash Naveen. This is each one of us self-prepared needle, which surgeon with decent technical and surgical skills can self-prepare in his operating room. We have 27 gauge, 26 gauge needle, we have 30 gauge needle, and we test different designs of them. This is our procedure. We target the suprachoroidal space. The position we aim is 4 mm from the limbus. Direction is bevel facing opposite to limbus. Area we target is temporal, no matter upper or lower temporal quadrant. And with gentle scleral pressing, perpendicular needle, we slowly inject and we feel under our thumb the low resistance of the suprachoroidal space. This is a video of Dr. Mishev&Marashi injecting and performing the procedure. You see how neat is the procedure. This is Dr. Farhat Abrar. Sorry for the little bit more light exposure on the video, but see the calm and relaxed injection. He uses his index finger, then he slowly withdraws the needle and complete the procedure. This is me, 4 mm from the limbus. I use my thumb for injection, perpendicular to the sclera, slowly pressing, and I like to check the pressure after the injection. The pathology we treat is diabetic macular edema, posterior uveitis, retinal vein occlusion with central macular edema, and pseudophakic central macular edema. These are our early results. A case from Dr. Marashi, resistant diabetic macular edema, pre-injection and first week post-injection. Obviously, there is a response from the tissues, and we hope that this edema would improve in the time. This is branch retinal vein occlusion, pre-injection, and 48 hours after triamcinolone suprachoroidal space injection with our Mishev&Marashi needle. Remarkable results, anatomical reconstitution and absence, almost complete absence of the cysts. This is case from Dr. Farhat Abrar, serpiginous choroiditis, pre-injection and 7 days after injection. RPE pathology has resolved and the normal macular structure has come. This is Farhat Abrar Vogtkoyanagi Harada case, 1.5 hours after injection and 3rd day after injection. The choroidal bump has flattened and the split in the photoreceptors has resolved, so the effect is really nice. This is another case, presumed tubercular multifocal choroiditis, pre-injecting, and in the 3rd day we already have a resolution in the RPE and macular pathology. This is a case from Arush Kuraha. This is retinal vein occlusion. Obviously, after suprachoroidal triamcinolone, we have a really marked and good anatomical result. Another case, pseudophakic central macular edema. The result is really fast, 1 week. we have resolution of the edema. This is a case from Dr. Mishev, presumed sarcoidosis. We can see the hot optic nerve and the edema and the spots, and on the third day and 1 week they are almost absent. This is the OCT, and we see on the 7th day after suprachoroidal triamcinolone a remarkable result. This is anterior segment OCT. We can measure the conjunctiva, tenon and sclera, and to see that the sum of them is around 800 microns in this particular case, of course. We see the suprachoroidal cleft. After injection, it is measured 382 microns. We can hypothesize that the soft tissues over the sclera are around the half of the length of the needle, and that's why we choose to use 1000 microns needle, which we think would be sufficient with or without additional pressing for almost all eyes. Of course, it will be better if we have a pre-injection OCT with which we can measure the scleral thickness or all the tissue complex, conjunctiva, tenon and sclera, and to adjust the length of the needle to be appropriate for every or for this case. Whenever there is inflammatory mechanism, we can use suprachoroidal space injection of triamcinolone. Suprachoroidal space injection of triamcinolone is feasible option for cases of diabetic macular edema or central macular edema due to retinal vein occlusion, non-responsive to intravitreal anti-VEGF. Injection of triamcinolone or VEGF blockage agents in the suprachoroidal space using Mishev&Marashi needle would potentially improve drug efficacy, reduce the potential complications, and overcome the external limiting membrane barrier which is present when we inject in intravitreal space. Response can be variable, as this is not a universal treatment nor a replacement for intravitreal anti-VEGF, but it can be always a great option in our arsenal. We can use it in addition with intravitreal anti-VEGFs also, like combined therapy. Complications and side effects. The most important thing that we see is that we haven't been seeing any IOP spikes, no suprachoroidal bleedings, no choroidal detachments, no retinal damage, just small subconjunctival bleedings, still no cataract seen, it's too early, and no steroid responders among our patients. Longevity and durability of this drug delivery method needs time to be adequately appreciated. Triamcinolone is one of the drugs we used. Anti-VEGF agents in combination with triamcinolone were also evaluated and applied by our team.